everybody. Are we missing anybody courtesy of the joys of the hoolie that was blowing last night? You will see the smoke camera that looks the nearest thing to a Dalek in the middle of the room. That was my plan at midnight last night as I was listening to the wind, thinking that everybody's going to get here. So what we're going to do this morning is we're going to record this, which means then electronically that can then be uploaded for those students that are not here. They can access this as a resource, and then additionally you guys as well can access this as a resource. So please ignore this. You'll become quite familiar with these cameras. They are used for part of our moderation and quality control purposes for exams. So you will see them in different guises. So see, that's the purpose of them as well. It wasn't quite the intention, but we're where we are. The plan for the next hour, because Shiv has you at 11 o'clock, is to introduce you to how we are going to run the Friday sessions. So the sessions between 11 and 1 for Group A, I think I've got that right, and 1 and 3 o'clock for Group B. These are timetabled as integrated neuromusculoskeletal practice sessions. These are new sessions that we have, well, new in the sense we've got 2 hours. These guys had 1 hour of them, and they were delivered in a slightly different way. Again, further to the feedback that we've had from not just your recent predecessors on the programme, but more previous than that, and the teaching team, we felt for a while that we wanted to have an opportunity, particularly at the end of a week, to try and draw the different aspects of the Neuromusculoskeletal 1 module together, so you start to see the bits. So you're learning evaluation, and in your head, evaluation, in your head anatomy manual therapy, in your head therapeutic exercise, but how does that all fit together? Because at the end of the day, you're not treating patients just therapeutic exercise or just anatomy manual therapy. It all comes together. So it really is to help you start to synthesise the information that you're learning throughout the week, and we are timetabling the sessions on a Friday to make sure that they pick up key things that you've covered over the rest of the week. They're not revision sessions, they are synthesising sessions. To give you an example of some of the teaching and learning strategies that we're going to use, we're not going to use panels every single week, but a clinical reasoning panel is an opportunity for us to start to help you start to develop the links. Okay, I think I gave you the analogy yesterday that we're giving you bits of a jigsaw puzzle, and what these integrated sessions are going to try and do is bring the bits of the jigsaw puzzle together so you've got a clearer picture. Okay. Hopefully, as you go through the module, rather than the penny dropout later on in the module, or even into other modules. So the 3 girls have come along this morning. I think you've met Becca already, met the other 2, Fiona and Claire, have very kindly volunteered to come in to give you a demonstration of the type of strategies that we use. Now, much of this, for some of you, you might be thinking, oh, this is all a bit scary. Okay, for them it was too. It still is. I was waiting for that, but I was giving you the opportunity to say that. But it really is to show you how we are going to use different aspects of data that we collect in subjective examination, objective examination, and how we link that data to your thought processes. So basically what the girls are going to do today, and I'm going to facilitate, is demonstrating to you the thought processes that they have. So we're verbalising what's going on inside their head, we're turning up the volume and they're coming out their mouths, to allow you the opportunity to see how we link certain aspects with different parts of the theory that you're going to be learning. It will all become much clearer come Fridays, hopefully. Just to flag up, this case study that I'm using is a case study that actually came from one of our clinical colleagues within the NHS, Alistair McPhee, and I've developed on it to make it into a clinical reasoning panel. So the data that you're seeing is actually live data that Alistair had from a patient that he was seeing within an orthopaedic clinic in one of our local trusts. Okay, so the aims of this panel, okay, and each week you will have a clear aim for what we're doing with our clinical reasoning strategies, is to start to interpret some of the subjective examination. We're going to help you to, what is a subjective examination, what questions do you ask, how do you ask them, but once you've collected all of that data, you end up with screeds of notes, and then you've got to actually think, what do I do with all of this? So part of the panel is to help you interpret what that information means to you and how that's going to help you formulate an action plan. By the end of your subjective examination, the intention would be that you would be able to plan a logical, structured, physical, objective examination. Okay. I haven't printed these off for you today. Okay, they will go up onto GCU Learn for you, so you can have a look at it retrospectively, because I just want you really to listen and follow. If you want to kind of take notes and think, oh, put the heading of the slide down and scribble some bits and pieces, but this will all be gone over specifically with you as we go through the rest of the module, so it really is just to observe. So, I'm going to introduce you to, this is what we're about to explore. As physios, we collect subjective interview data and we collect objective physical examination data. Okay, that's what we do routinely in all aspects of our practice, but certainly within neuromusculoskeletal 2 and 1. What we're looking at really though is, at the moment, we are teaching you the theoretical aspects. Okay, you've not hit clinical yet. Okay, you'll hit clinical fairly soon. We are exploring aspects of pathology, biomedical sciences, neurophysiology, biomechanics, anatomy, theory of manual therapy. So this is the bits of the jigsaw puzzle that you've got at the moment that are very university-based. What we are going to start to do is develop your ability and what we call is your clinical reasoning competencies. The medics tend to call that just clinical decision making. We're exploring your reasoning as to how you link the two things together. So we're going to play with that. This is a very well recognised concept presented by Jeff Maitland, who we're going to talk an awful lot about in terms of manual therapy, and you'll have an opportunity to read some of his texts and some chapters that talks about this semi-permeable brick wall concept. Okay, so we have a case study. We're going to do a staged release of the data, and again, what we're going to be exploring is with each release of data, how that links to the formulation at the end of our subjective examination of a hypothesis. Okay, we're not saying a diagnosis. We've done our interview. We've not done our physical examination. We're moving in the first stage of this to the point of, so we finished questioning this patient, what's going on in my head before I even start to examine them about what is wrong with them, okay, or what might be wrong with them, and how that might then inform you as to what tests that you need to do to prove or disprove, so you can be effective with your time. Okay, so very briefly, now we could spend the next 2 hours talking about this slide, but we won't. 40-year-old female, ladies, what's your thoughts at the moment about a 40-year-old female?
Her healing time might be slightly decreased as your age increases, your healing time decreases. So if she's gone through, we don't know what it is yet, but if she's gone through some sort of trauma, then the healing time for that might be slightly longer than you'd expect in younger patients.
Okay, I'm going to stop a second. Can everybody hear at the back? Because that is a point. If you can't hear, can you sort of wave? Okay, they are well used to me screaming at them. Big climbers. Okay, so we're thinking 40 years of age is kind of, it's not old, okay, in our ageing population, but we're still kind of in the, it's middle-aged, we're moving towards middle-aged. Okay, so we might see some changes within healing. In terms of pathologies that may or may not be present, okay, thinking about that age and that gender, is there anything that's going through your head at the moment?
At that point, I wouldn't expect her to have any arthritic change if she was in her bubble, and wasn't subject to any abnormal strains, or she'd had any previous injuries. At 40 years old, you wouldn't expect her to have many arthritic changes.
Okay. Can you qualify for the benefit of the students, when we're talking about arthritic changes, are we talking about pathological changes, or are we talking about something else, or could we be talking about something else?
It could be just due to pain, or you might start to see some actual physical changes, so changes in the joint capsule. You might get some bony spurs, things like that. But arthritis is so varied that sometimes they have pain without change, but sometimes they have change without pain.
Okay, so we may have, and that's qualified your, maybe somebody else in the panel can qualify your bubble. What do we mean by bubble?
Bubble's kind
It's
of
a Fiona-ism, but yeah.
your person who isn't influenced by any environmental factors. So things that kind of remove your bubble, like occupations, hobbies, any stresses, children, past medical history.
So we're talking about intrinsic factors that might contribute, that come with the person, internal to them, versus the extrinsic factors that might, the person's obviously interacting and engaging within a wider environment. Okay. If we're thinking of arthritis as a pathological process, so osteoarthritis, or we might be thinking about an inflammatory arthritis, which we could explore, and you guys will be in Neuromuscular 1. We'll look at degenerative arthropathies as well as inflammatory arthropathies as part of your theory module with Emma Jane. Could there be any other reasons for degenerative changes?
She could have slightly early onset of osteoarthritis, but again, if we're looking at her in our bubble just now, we can say that exclusively. But if things like her occupation or career or personal circumstances could increase her risk of having an slightly earlier onset of that, because you most likely see that from someone about 50. So she's maybe slightly early, but it would just depend.
Was that sorry?
Kind of like if you're looking at past medical history and other factors, although she's 40, so you expect to be premenopausal, but if there's other factors, like if there's a previous medical history or hysterectomy or kind of any medical conditions or dietary problems that have caused lack of calcium absorption or something in the past, you might start to see some osteopenia or osteoporosis at this stage.
And obviously, for very obvious reasons, we wouldn't necessarily, although osteoporosis and osteopenia can be problematic for males as well. We tend to think it's very female predominant, but it's not. But we are thinking that there's probably a greater risk and a consideration for us with a 40-year-old female versus if we had a 40-year-old male. Okay, so as I said, we could continue exploring lots of things just on this, but we're not going to at the moment. So at the moment, you've already got some thoughts in your heads about things that you might need to follow up on with regards to the data you're going to be collecting underneath past medical history, general health issues. Great, okay. If we move on to the body chart, okay, now again, with this I'm not suggesting at all, and we're going to talk about that next week, that the body chart would be the next thing that you must collect. Okay, so again, we'll explore that as a group next week. But let's just take the body chart as the next piece of information that we have collected. This patient has 3 symptomatic areas. Her predominating symptomatic area is area A on her right knee, and she describes that as a constant deep ache with a visual analogue score, 0 being no pain, 10 being the worst pain you could possibly imagine that she's experienced in the last couple of days. She experiences that pain 4 at best, 6 out of 10 at worst. Her second area of symptomatic problems is also on the right knee, and that's round the outside. She describes it as being around the outside of her patella, and she describes that as an intermittent sharp shooting pain behind the kneecap. Okay, so she's reporting it as being round, but it's sitting underneath the kneecap. And again, it's an intermittent pain, so she's periods that she has no pain whatsoever, but when she does have pain, the maximum pain that she would report is 8 out of 10. She has exactly the same symptoms on the left knee as well. Okay. She has the tics indicate that she has no other symptomatic areas. That was clarified in subjective examination. She reports no pins and needles or no numbness. Okay, ladies, let's just think about symptomatic area. There's 3 for you, so let's take one each. Let's think about symptomatic area A. Okay. Who's going to pick A and tell me what is your thinking at the moment?
Because it's a deep ache, it suggests it's a deep structure rather than a superficial muscle or something. So kind of thinking joint or kind of into the joint and kind of menisci.
Okay. So when you say a deep structure and you're saying joint or internal joint structures, why are you saying that as opposed to something that might be superficial?
Just the description of the pain being a deep ache. So if it was superficial, it tends to be more kind of localised to that area.
Okay.
And it's kind of a more generalised term, and because it's a constant pain, it suggests that there's not an on-off presence.
Okay. Can we hold the thought on the constant and still stay on the deep? In terms of that description of being a deep ache, you've mentioned joint. Is there any other structures that are deep that you might be thinking? You've talked about internal structures, and you mentioned obviously for the knee we've got menisci, which is specific to the knee joint.
Ligaments as well might be.
Yep. Okay.
Considered. It doesn't really fit, like if you're just considering the deep kind of ache, might start to consider kind of nerve kind of issues because it's the constant pain as well.
Okay. Is there anything that might make you think it's less likely to be nerve?
I think the deep ache kind of makes it think less nerve, and it's not the shooting, stabbing, pins and needle, lancinating pain.
So the description of it in terms of ache makes you think it's less likely to be nerve, not excluding nerve, but less likely to be nerve. Okay. What would you expect it to be if you said it was kind of sharp, shooting, stabbing, burning? It's a very different description. Okay. Why did you think, when you said it could be knee or it could be menisci, when we're talking about knee anatomically, knees are complex. What specific joints would you be putting in your list if you were writing that down at the moment?
Of the patellofemoral and the tibia.
Did you all hear that? Tibiofemoral or patellofemoral joint. Okay, so we've already we've narrowed down that we've got joint structures, but we're differentiating those between the fact that your knee complex is a complex, it's not actually a joint if we're being really correct in anatomical terms. Tibiofemoral, the joint between the tibia and the femur, versus the patellofemoral. Okay. If we're thinking ligamentous structures anatomically, what slides are flying into your head at the moment? Could it be in that area? It's anterior aspect of the knee?
ACL.
Can you not abbreviate for me?
Anterior cruciate ligament.
Yeah.
And the lateral cruciate ligament possibly. But
Yeah.
what more likely to be the ACL.
Okay. We could explore why we think it's more ACL, but we won't at the moment. Okay. Can we just go back to your comment about the description of being constant? What does the information about it being constant suggest to you?
If it's constant, it suggests it's not a mechanical type pain that has an on-off kind of, when you do a certain action it comes on, and if you do something else it eases off.
How would that be described?
It would have a vascular polystarting zero, and it worsens with a certain activity.
So it'd be intermittent.
Yeah, and the constant suggests it might be inflammatory.
Okay. If we're thinking it's inflammatory, I'll ask somebody else in the panel, we can rest for a moment. If we're thinking it's inflammatory, when we go into other parts of our subjective examination, what are you expecting to find when you question the patient if we're thinking it's inflammatory?
So if you have a look at your 24-hour pattern, you might get stiffness in the morning, almost like a gelling, and it's just kind of, everything's just a bit gunked up with the inflammatory mediators. You would expect it to get slightly better through the day and maybe worse at night time. But you would expect if you were doing activity it would get a bit better because you're going to get blood flow to those areas, and that's going to start to wash out all of those inflammatory mediators.
Okay. Claire, is there anything else that we would find in our subjective examination that would support Fiona's hypothesis that this constant pain is inflammatory?
You might also find within their 24-hour pattern that they're having some sleep disturbances. It's quite often throughout the night, and you're getting all that build-up of the exudate, like inflammatory substances within the area, or just it could just be from them like rolling over if they're hitting the area and it's quite sensitive at that time, so then they could disturb their sleep.
So within our pain behaviour and our exploration of pain behaviour in that 24 diurnal pattern, we're looking to see potentially worse in the morning, worse in the evening, some sleep disturbance. Any other clues we might get in our subjective examination to back up Fiona's hypothesis? Because this is at the point the first thing the person said to you, and you're already beginning to think, there's inflammation. So you're already beginning to think, okay, what's in my kit bag that I can use as an inflammatory process here?
You would have a look if they had started any medication. So if they were on anti-inflammatories and say the pain was a constant 6, but it's going and they're having periods of 4 out of 6, so if it's getting slightly better after being on the anti-inflammatories, that might show that's an inflammatory process as well. Whereas if there's no change in symptoms and they've been on the anti-inflammatories for like quite a few days, or maybe up to a week, and there's no better, it might not be inflammatory.
Okay, great, well done. Any other clues we'd be looking for?
There's been an injury recently. You kind of expect inflammation to be there the first few days after the injury. So if they've injured themselves recently, you're expecting that kind of inflammation type pain to be present.
Okay, so in terms of that, we're then talking about the inflammatory pattern and how long we expect to see it. Which part of our subjective examination are we going to gather that information in?
History of presenting condition.
Yeah, so history of presenting condition. How long might we be expecting, thinking about our timelines of an inflammatory pattern? How long might we be expecting? When do you think this, if we're talking about traumatic incidents, how long do you think we're talking about?
You would expect to see them within the first couple of days after the incident itself, they would still have that inflammation going on in their system, but it only lasts for about 3 to 5 days maximum in most people, and then they move on to the second stage of pain.
You'd also have to consider though that if somebody's not taking the appropriate preventive mechanisms, they might get that self-perpetuating, so it's going to keep being inflamed if we're not protecting it enough.
So that might not fit our nice theoretical timelines, and there's some fairly seminal papers that come out and they give you nice little graphs that show you the timeline of inflammatory peaks and then when it starts to wean off. But we remember that our patients don't live in that bubble, and they may be doing things that are going to self-perpetuate, so we need to explore that under history presenting condition. Good, okay. We're not going to explore too much more about differential diagnosis of structures. I just want to pick up, let's take B and C together because they would seem to be very similar, if not the same. What are we thinking about when we look at the information that we've got for B and C?
They look like they're more mechanical issues. Building on what Fiona has already kind of touched on, if it's intermittent, there's obviously things that are making the pain worse for that area, and then things that they can do that are easing the pain off completely. So for this patient it is, they can obviously do something, or in a certain scenario where they don't have any pain at all in that area.
Okay. So for A, we're suggesting there's a physiological process that's going on that may be an inflammatory pattern, but for B and C, we're thinking it's more of a mechanical. There is something that, it's like the light switch, something has been triggered that's loading tissues, they are becoming symptomatic in response to that load, and then you're offloading or you're doing something to take the load off. Okay. Can I ask then about the description about sharp shooting pain? Fiona mentioned that sharp shooting burning is suggestive of nerve. Can you dig yourselves out of the...
I was going to say based on that you can't rule it out.
No.
You would need more information.
What makes you think that it may or may not be nerve based on the information you've got in that body chart?
It might not be because of the distribution of the pain. It doesn't follow a route of a nerve, like where you normally see the pain pattern. If it was a nerve condition, that's very specific. I don't remember seeing that.
So we were talking about the distribution of if a nerve, it's a nerve problem. If it's a spinal nerve route, what would it most commonly, how would it be distributed? What kind of patterns do we learn?
Well, like the most common one that most people would know is like sciatica, so you'd get that straight down the back of the leg.
So it could be a dermatomal pattern that's indicative of the distribution of that one particular spinal nerve route covers in the skin and upper or lower limb. Or it may well be, what other nerve structure would we be thinking about if we're not thinking of a spinal nerve route? Way up here?
It could be peripheral, so it would follow almost like a cutaneous distribution.
Yeah. So the area doesn't make you think that it's nerve, although the description, you couldn't rule it out. Okay. In terms of structure, Fiona kind of has highlighted that the area and distribution for A made her think from a joint, and the deep A, it was potentially a joint structure, the joint being tib fem, patellofemoral. In terms of the distribution for B and C, what's your thoughts on what the structure might be?
Well, it says behind the kneecap, that's where they're feeling the pain most, so you would then rule in again your anterior cruciate, your possibly posterior cruciate as well, just from the origin and insertions, and then the meniscus as well.
You could also consider that there's maybe wearing of the cartilage behind the patella. So there might be some slight rubbing if it's like mechanical, and she's getting a bit more friction, and then that's just giving her that shooting pain.
So patellofemoral and perhaps still the internal structures of the tibiofemoral joint are there, but we're not necessarily thinking that we would have kind of degenerative changes in the tib fem because it would be distributed possibly in a different area. Okay, right, will we move on? So at the moment we've got some thoughts in our head. Let's move on to aggravating and easing. Okay, now, let's think about this in relation to A first of all. For the purposes of the audience, just to clarify, the aggravating factors on the left link directly to the easing factors on the right. So, for example, symptomatic area A increases with driving greater than 20 minutes, and it increases to 6 out of 10. Okay, she's aware of it after 15 to 20 minutes. She can continue, and the intensity remains in status quo, ISQ. If after that period of driving, she then stands up, so they go together, you can put 1, 2, 3 because they run across. If she stands upright, she moves around, her symptomatic area of A reduces within 5 minutes. Collectively looking at those 3 aggravating factors, because I don't want to leave with this too much today, collectively looking at those, how does that inform you about the irritability of the tissues?
I'd say it was non-irritable because, especially for the first one, it takes 3 times as much time for the aggravating factors to come on than it does to ease it. So it can be eased a lot quicker than it can be aggravated.
We're going to talk a lot next week. One of the key objectives for next week's integrated session is to look at how the SIN value, severity, irritability, and nature, which is a Maitland concept, impacts on your planning of your objective examination, your execution of your objective examination. And the aggravating and easing factors are very clear indicators of how we can correlate the irritability of the tissues. So how irritated are those tissues? If we went all CSI and looked inside the tissues, how irritated are those tissues and how likely are they to respond to load that's placed upon them? So as the girls have highlighted, it's the relative time to increase versus the relative time to reduce that helps us gauge the irritability. So based on that, as very clearly stated, we would say for symptomatic area A, that would be non-irritable. What that means for us in terms of objective examination planning, the girls will tell us when we get to that point. What about symptomatic area B and C? What's our thoughts on irritability?
Irritable. Well, it's coming on immediately, so if we were putting our hands on the patient, if we put them into those positions, her pain would increase immediately to 8 out of 10.
Yeah.
So it would restrict us a lot more than her pain would.
Yeah, okay. In terms of the relative time to settle back down again, so it takes longer to settle than it does to stir up. So B and C are quite different from A. Just looking at B and C, from the information of the aggravating factors, does that help you sort out your thoughts with regards to, is this ACL, PCL, patellofemoral, meniscal? Is there any clues within that that make you think, from your knowledge of where those anatomical structures are, the functional capacity of those anatomical structures, how they might respond to movements of going from sitting to standing, ascending, descending stairs, squatting, kneeling?
I would say it's kind of pointing towards patellofemoral, because in all those movements you're getting that gliding of the kneecap over the condyles. So that's actually been, so if you thought it was a mechanical pain, it's in all those movements that structure is actually being moved in.
Okay. We could debate, and in class we will be debating why we would be ruling it out, or could we still rule out ACL, PCL, menisci at this point, but that would be a supporting argument for patellofemoral. So we can start to see how we would play with that data. If I go back to A, aggravating factors, is there anything within that that helps our differential diagnosis that we had of, again, internal structures of the tibiofemoral joint and or the patellofemoral joint?
We couldn't rule out meniscus because it's in a knee bent position that a lot of the aggravating factors are coming on. So it may just be that we're getting slight pinching or some slight aggravation of that there.
Okay. The positions that they are in of flexion, do you think they're in sufficient degrees of flexion, knowing what you know about the mechanical properties of the menisci as you go from full extension to full flexion?
You would expect it to be most provoked at about, is it 20 degrees? So if you're prolonged sitting, I suppose it depends how you're sitting, you can't say that. The driving might irritate it, but that'll depend on how close they are sitting to the pedals, but the walking.
I suppose what I'm getting at is you going back to the knowledge that and your understanding that you gained in the neuromusculoskeletal evaluation module with Tom, where you did your special test procedures, and you looked at those specific tests that you put load onto the menisci. What positions did you have to put the knee into to perform a valid and reliable test for the menisci?
90.
Slight flexion and rotation.
Okay.
Rotation.
Just slight flexion?
And we thought it was 90.
Fiona?
Depends what test you do. I know, I'm thinking of the compression.
Okay. And this is a really good point that on a panel, okay, we are not expecting you necessarily all to agree, which is quite common. Equally so, you're like good professional debate. Equally so, there may be points on a panel where collectively you actually highlight that for the panel, I'm not really very sure. And that usually gives my response of, we need to go back and explore that. Okay, and that will be the teaching and learning strategy. It won't be me saying, well, no, this is the definitive on it. So this is a means of us then saying to you, well, where is the gaps in your knowledge, or where are the misconceptions in your knowledge that you've got two bits of the jigsaw puzzle, but you actually want to just snip a bit off to fit it in. So it's that whole idea of then going back and re-exploring where you're at. Okay, so if that was in the panel, I'd be saying to girls, you need to go back and you need to look at from your anatomical textbooks, from your validity and reliability of your special test, clinical examination test, what position and how does that information then inform, does it fit? Yeah. I will move on. Okay, 24-hour pattern. You told me that you thought if it was an inflammatory pattern that they'd be worse in the morning, worse in the evening with some sleep disturbance. Does that support or not your working hypothesis? For E. Isn't it annoying when patients don't follow a textbook? What's your thinking then?
You would expect it to be better when active if it was inflammatory
Okay.
in the hearing.
So it's maybe more related to loading. If it gets worse with activity, then I suppose.
Cloudy, because as you become uncertain, it all gets quieter. They're being very polite at the back and not waving to say I can't hear you. Yeah.
Yeah, sorry, just wanted to know what O, W, and O are.
On awakening, good point. On awakening, on rising.
Okay.
So there's a difference between you open your eyes before you get out of bed, listening to the wind blowing at however many miles an hour, and then swinging your feet over the edge of the bed, plonking your feet on the ground in that first 5-10 minutes. And that could be a good point, is that could be any time of the day. If you've got people that work shift patterns, that could be so whatever their diurnal variation is.
Is it common to see changes between the O, W and OR?
Do you mean in terms of standardisation of
Yes.
documentation? Yes. Yes. Okay, we'll pick that up. People will document that differently. We'll explore within the Friday class what is the value of presenting it that way. Again, we do not advocate this as the definitive way. You go out, you all do a minimum of 1,000 clinical working hours as part of your pre-registering programme. During that time, you'll have an opportunity to work with a variety of practitioners that will record and document things in different ways. How does that way facilitate your reasoning versus how would that way perhaps not facilitate somebody else's reasoning? Okay. You should begin to get an idea that on awakening versus on rising, there's different loading mechanisms that are ongoing, so they should be telling you something different. And how does that then inform your thought processes? Around about what the girls are highlighting, is it mechanical loading, inflammatory, or is it inflammatory plus or minus a mechanical? Okay, so we have got some issues here. The fact that they are symptomatic on rising, they do have their symptomatic ADA. It might not be the worst that it is, but they do have their symptoms on awakening. So before they move out of bed, they have got symptoms. Yeah? Their sleep is undisturbed, maybe not the best subjective information in the world, but it's undisturbed. That's not to say that they don't have symptoms. So is there an indication, the fact that they are showing that there's symptoms throughout the day, that there still could be inflammatory symptoms there?
It might, if it's been trauma, it might still be in a fairly acute phase, so they might be in a constant state of pain because the body's just trying to heal.
But it is telling you, and I think we would need to explore your understanding of inflammatory pain would ease with activity, because that's not always the case. If we then delve deeper into our physiology behind inflammatory pain, that might not be the case. So at the moment we're not ruling it out, okay, but it's not fitting a classic pattern. Yeah? Okay, if we move on to special questions. What does this do about your thought, tell us about your thought processes? So she's reporting that she is swelling intermittently, right more than left. Not sure whether it's with kneeling activities, but she's suggesting it may be. Giving way, she said one episode of it giving way on the right about 18 months ago, 12 months in a year. During training camp, She's had no episodes of giving way since. It's locking her knee. The right one, she feels a catch, and it can get stuck when she's trying to straighten it, so it's when she's going from flexion to extension, particularly in that loaded position, so it's squatting and then coming up to stand. Okay, going from flexion to extension in an open kinetic chain pattern, non-loaded, doesn't seem to be a problem for her. Her left leg, she gets a nipping pain but no catching. Inverted commas means that's what the patient's reporting, what the patient actually said. So, in terms of symptomatic area, well, the 3A and B and C, what does that information suggest to you?
It makes me think patellofemoral syndrome more, because the kind of catching kind of feeling when she's trying to straighten it, it's when the patella's trying to clip back into the gap, it's not quite smoothly going in.
Yeah. So, in terms of the patella, what are we really talking about then?
The kind of gliding of it.
Yeah, so the gliding of what aspect of the patella onto what aspect of the femur. So when they get to week 3, it rings a bell when they're learning their anatomy for the knee.
The patella onto the femoral condyles.
Yeah. Okay. In terms of, you're saying it moves you towards patella because of that idea of, and you're right, it's the patellar tracking. As it goes from flexion to extension, your patella is obviously a sesamoid bone that sits within your quadriceps mechanism that's going to facilitate that flexion to extension. Would that information rule out menisci? That's definitive. I agree. Why?
Well, especially going from the sort of flexion up into extension, if the meniscus is getting caught, then it could lock out, but you should be able to then actively bring your leg out into extension, if that makes sense.
So what you're highlighting is the menisci. What's the function of the menisci?
Shock absorption. It's
Yeah.
kind of like a wee sponge that sits between the two bones.
Does it do anything else other than shock absorption?
So
I'm thinking about the shape of it.
not protect against rotation, absorption.
It'll have a role in controlling the rotation. Is it flat?
No, it's higher on one side and curved around.
So it's concave. Yeah, it's a concave surface, so it helps to improve the congruence of the knee, but it will also have a role to play with. Obviously, that congruence will have an influence when you're going from flexion to extension, and as you said, you pick up the rotation as your knee goes from flexion to extension. So we couldn't rule out, because of the position of the meniscus, because of the attachments of the meniscus to the tibial plateau, we couldn't rule out the fact that the meniscus might be a part of that catching. Okay, so we're using some of the clues that the patient's giving us to knowing how does the meniscus behave, okay, and how does that fit. Okay, so let's move on. History presenting condition. We thought that there may be trauma because we were having an experience of constant symptoms. So this patient reported a long-standing history of intermittent right knee pain in excess of 20 years. So she's now 40, so we're talking about from her late teens. But her symptoms were similar to the symptoms that she's reporting, the round the kneecap, one and just underneath the kneecap. At that point, there was no history of trauma or specific injury. It was an insidious, gradual onset. She gradually noticed clicking and crunching, again her words, with a varied kind of incidence of symptomatic area B. She started an outdoor fitness camp for 18 months prior to coming in to see Alistair as she was trying to lose some weight. She noticed at that point a rapid, sudden increase in the incidence of symptomatic area B. She only managed to do the training sessions and she had to drop out because she was experiencing this much more, it's intermittent now, but she was experiencing it much more regularly. She rested for 3 months. We could explore what rested means for the patient. And it settled back to its original kind of chemo wane level. Okay, so B was there for a while. She went to gym, okay, June, prior to seeing Alistair, and she had a personal training session programme set up where they added treadmill running to her fitness plan. At that point, yet again, symptomatic area B flared up, and at this point she then noticed the symptoms onto the left-hand side. She was aware of A at that point, okay, but the other two, the B and C, were more problematic. She stopped all of her running activities and her symptoms settled, notably left leg symptoms more so than A and B. Okay, so Moving to the current time, so the point at which she was seeing Alistair for her first initial appointment, she was complaining of constant symptoms of A, lower intensity than it had been when she'd been doing her running, and intermittent episodes, B, more than C. What's your thoughts now we've got history presenting condition?
I would say patellofemoral.
Why?
I know that, I know you can't say this as good, but in a lot of patients, patellofemoral symptoms can actually be flared up by increasing activity too quickly.
Okay.
So they might, so basically they're not getting that proper tracking of the patella, and that might be if they've gone from quite a sedentary lifestyle to quite an active one, that they might not have the appropriate strength in their quads to actually get that tracking in the right position.
Okay. You've used a really valuable point. So we're saying the contributing factors to that, it's not just the increase in load, but the contributing factors is that the intrinsic ability of the patient's body is not capable of coping with the additional extrinsic factors. You talked about strength. Now, evaluation, we talk a lot about how you measure muscle performance, whether we're looking at strength, whether we're looking at recruitment, whether we're looking at endurance, whether we're looking at power. Our sports scientists will get all excited all about that. What are we thinking? Is it strength? What else do you think might be an issue? If we're talking about tracking mechanisms of the patella.
It'll be recruitment, so our VMO might not be activating as quickly as it should be, so our vastus lateralis vastus medialis oblique. So that's the one, it kind of, when it turns on, it almost pulls your patella in slightly before your vastus lateralis kicks in. I'm going to be easier to show you. So like this bit here, this bit here should turn on slightly quicker to pull your patella this way before this one pulls in to almost bring it back to central. If this one doesn't turn on in the correct pattern, this one will have an abnormal pull over to the side, so the patella almost is being pulled out of its track.
It's not dislocating in most cases, but what it isn't doing is it's like driving on the hard shoulder rather than driving on the main motorway. Yeah. In terms of, that was a really good description, in terms of other muscles, because you talked a lot about the quadriceps mechanisms, are there any other biomechanical considerations that you might have with regards to muscles that might be problematic, that the body might not be prepared for?
You'd also have to consider like glutes, because they'll attach into the iliotibial band which runs right down the side and into the patella, so if they're slightly tight, you might have a tightening, well not a tightening in the band, but a tightening in the glutes, which is tightening that band almost.
Need they just be tight, or could they be not so clever at switching on?
Yeah.
Which glutes in particular? Attaching to iliotibial band?
Glute max.
Yeah, so gluteus maximus, and attaching to iliotibial band along with which muscle?
Tensor fascial lateral.
TFL anteriorly, glute max posteriorly, joined together, iliotibial band down the lateral aspect of the femur, attaching into the lateral aspect of the patella. Great, well done. Any other biomechanical factors that might be intrinsic to this person that she might have started with or might have developed?
Her gait in general, just the way she walks, or in this case runs,
Yeah.
might be slightly altered, so then the forces that are then being pushed up through the knees could then alter the position of the way her knees are aligned.
Yeah, exactly. Anything else?
I want to kind of consider proprioceptive issues, because she doesn't know where that her knee is, and then you're not getting the correct position. That's going to add like extra strain, because it's kind of similar to an altered gait pattern would.
So it may well be that the muscles have got good strength, if you want to call it that at the moment, for want of any other description. The muscles are recruiting correctly, but what's not happening is the right information being sent to the muscles to get them to perform in terms of your proprioceptive input. Equally so, she may have issues down at her feet, biomechanically, that might then be influencing, as she started to add in a greater loading mechanism into her regime, that then she's not coping, so we need to be looking at her feet. Okay, so we could explore lots and lots. Additional information, nothing in her past medical history, drug history, non-steroidal anti-inflammatory drugs. These were non-prescriptions, these were over the counter. She was taking them 3 times a day, and she was taking paracetamol, so straightforward analgesics, 3 times a day, or as required, but at that point she was taking them fairly, and they were, what should be written on there, and they were having some effect. What does that suggest to you?
That there is some form of information if the anti-inflammatory behind the effect.
We would suggest that. The purposes of the audience, this programme does not qualify you, it's not within your scope of practice to comment and prescribe medication. However, your working knowledge of medication, we do need to build up, and how that informs your clinical reasoning and how that might then inform your need to communicate with somebody who is qualified to discuss medication, whether that's a local pharmacist or whether that's a general practitioner or a medical personnel. General health, nothing to know, and no family history. So, this is a bit that some of you might have wanted to start with. This lady was a full-time shop assistant. She worked in a cash register, 8 to 10 hour shifts, standing more so than sitting. Her normal regime, and currently, was to go to the gym twice a week, elliptical cycle, treadmill walking, more than cycling. Okay, she'd stop the running part of it. What does that suggest to you about the intrinsic and extrinsic factors that this patient, you're kind of commenting on why the increased running might be problematic?
Looking at the work she does as well, as she's standing all day, a lot of people tend to stand kind of preferentially on one leg.
Like I'm doing. Yes.
So then you're going to get, if that's been over a sustained period of time, you're going to get increased force transmission up that one leg, and then possibly increased changes.
Yeah, so she's not going to have symmetry. We already know that she's symptomatic more on one side than the other. Yeah, okay, so we've already got occupational risk factors that might be predisposing her to this problem. Anything else that says to you? How does she fit with all things physical activity? As advocates, as contact practitioners, we should be advocating physical activity, not necessarily exercise, but physical activity for our patients. Where is she sitting in that?
Depends.
How long she's at the gym.
Yeah.
If she's
Sorry. If she's walking, is that just a kind of slow dawdle, or is that actually fast walking where she's then going to get her heart rate up?
Okay. What are we aspiring to?
150 minutes a week of moderate activity over 5 days. And if you're doing more vigorous activity, you can do it in less sessions.
If at this point there was concern and agreed debate on the panel, you would be sending off, that's factual information. Is that factual information correct? A bit like the anatomy. If it's not correct, you go back and double check. So we'll be bringing in theory to add to that. Okay, so we're looking at this patient in its entirety. Manual therapists in particular, and musculoskeletal therapists, are often criticised for being reductionist. Okay, we narrow in, we get so obsessed in where the pain is, visual analogue score, where it is, how it behaves, and we tend to forget that actually there's a patient attached to all of this. You can start with this and see the patient in the bigger perspective before you start, and then narrow down into the minutiae, or we can do it in the order that we've done today, and we're going to explore that over the next 12 weeks, and certainly into NMSK2 probably even more specifically when we get to that point. But we're looking at the patient as a whole. Okay, what is that patient doing? You see them for half an hour at a time. However, you need to think what's happening to that patient in the 23.5 hours that you're not seeing them. Okay, so we've explored bits of this. The girls will testify that we can spend easily 3 hours getting to this point, so this has been whistle stop. Yeah. We will unpick things in depth, covering things in relation to pain mechanisms, in relation to pathological presentations, in relation to your knowledge and understanding of objective tests. Okay, so it depends what we're looking for to try and guide your knowledge and understanding. But we've explored some of them. We've looked at some history, signs and symptoms. What we now need to think about is, okay, where does that take us? We're not looking to get a diagnosis between subjective and objective, but what's our working hypothesis or our preliminary diagnosis that we are going to be trying to prove or disprove? Okay? It's like any piece of research. You collect the data that should be valid and reliable, be it subjectively or objectively, and then you try and prove or disprove that, and you evolve that and monitor, see whether that's effective or not. So, severity. You told me earlier that A was non-irritable, B was irritable, B and C were irritable. Severity, for the purposes of the guys in the audience, what's your thoughts on, well, what is severity first?
How severe?
Thank you, Claire.
How bad
they are, if that makes sense. So like how badly their condition is affecting their lifestyle.
Yes. So the impact of a range of different factors that are going to contribute to their presentation. So in terms of severity, what are we looking for? What kind of things tell us about the severity?
Sleep disturbance.
Yeah.
Pain, severe or irritable. No. Constant or intermittent.
Yeah. So the incidence of the pain.
If they've given up any activities because of their pain.
So disruption to activities of daily living, recreational pastime, sports, hobbies. Yeah.
How many pain areas that they've got.
Yeah. So a number of symptomatic areas.
Their VAS scores.
Yeah. So the intensity of the pain.
They're managing at work.
Yeah. So there again, that links into some vocational, occupational disruption. So what's your judgment? There's a few others, but what's your judgment of this patient? Mild. Your options are mild, moderate, or severe. And there's no balancing in any fences.
I'd say mild.
Do you agree, Fiona?
My initial thought was mild because she's still going to the gym. She's still able to drive and walk for more than 20 minutes, which
These symptomatic areas.
Yeah.
And it's constant, it hurts.
well, obviously, but if you just look at the pain, I would say moderate.
Uh-huh.
But she's not getting sleep disturbance, and there doesn't appear to be any impact on any kind of lifestyle factors. So
Yeah.
it would depend on probably when you speak to her how she kind of presents it to you and how much.
So we're in agreement that it's not severe, but we're suggesting that it could be moderate, but we're moving moderate to mild. Yeah? We are balancing on a fence.
I said mild.
Okay. What influence is that going to have on your objective examination? So let's, for the purposes of the objective examination, say that it is mild.
It would really limit us that much. You would just need to consider for the things that aggravate her pain, you would just limit putting her into those positions or avoid the ones that make her.
Okay, so it's the vigour of your examination. It's how far, when you're doing your objective examination, one of the common issues that we see with inexperienced practitioners, be it students or qualified practitioners, is that they are frightened to push the test to the point that actually you get valid and reliable information. They stop short of it. Then their supervisor comes in or their practice educator comes in and they do something and you get a completely different result. So what this is about is actually determining what is the vigour and how far can you push the patient to get valid and reliable information that's going to then help inform and either prove or disprove your working hypothesis. So if it's mild, what we're suggesting then is that we're going to push it, and next week we're going to talk a lot about this. Are we going to push it to the onset of pain, the limit of pain, and are we going to do overpressure? There was no which?
There's no overpressure.
I would probably do overpressure and all of them apart from the aggravating factors.
Okay, so that's one option. Over the panel, not everybody would agree. Okay, it may well be that some folk will say, well, actually, I'm going to stop at limit of pain and I'm not going to overpress any of them. Okay, and again, that's a professional debate and we'll explore that with some case study examples. What's the impact of the fact that symptomatic area you determined was non-irritable? How is that going to affect your objective examination?
You can do quite a few tests and you can repeat them quite a few times, well, as many times as you want.
Yeah. So our irritability gauges how many tests, what's the repertoire, how extensive. You're going to yawn, do that, because then you get caught. If you're going to explore and somebody is irritable, what we want to do, if they are irritable, you reduce the number of tests to a minimum. You don't want to aggravate something. Okay? If somebody is non-irritable, you can do whatever test you like, limited only by resources and time. Usually that's the biggest limitation. So for the purposes of A, okay, we said it was non-irritable, so you could pretty much do whatever you liked. You've got the slight quandary that B and C are irritable based on your determination, so you would need to be slightly careful that you weren't aggravating those at the cost of obviously getting information about you. What's your nature? Nature is our preliminary diagnosis. What do we think? So at the end of your subjective examination, you students are going to come out to your practice educator and say, this is what I found. Okay, your practice educator is going to ask you to tell them what they found and what you're going to go back in and do objectively. Some of you are smiling because you'll remember that painful moment. Yeah, and you think, what am I going to do? Okay, so in terms of nature, what are you going to say to your practice educator?
possible malalignment of the patella, so causing their pain. But that could either be due, we don't know the objective data yet, it's either due to possible muscle weakness or overactivation or potential gait issues.
Okay, so we've got biomechanical factors that might be impacting in a biomechanical problem, affecting which joint, structures, regions, potentially to patellofemoral joint, bilateral, right more than left. And if I was probing into pain mechanisms,
Peripheral nociceptive inflammatory
yeah,
chemical inflammatory with associated mechanical pain, perhaps.
positive. Don't add the perhaps. Be confident in what we're thinking. Okay, what that would then lead you to, and we're not going to do it today, but we're going to talk about determination of flags. There's lots of colours of them, and we'll talk about that. Because again, it may well be there's certain influences that we would have to then override, and that would have an impact on what we were going to do if we were actually going to do anything at all. By that we mean, is an objective examination indicated? Is there any reasons we should be concerned for this patient? Was there any indication that we need to refer them back to a medical practitioner because they've got red flags in particular, which usually indicates that there may be indications of serious pathology such as malignancy, in which case we would not be doing anything with them. We would aim them back to medical personnel. If there were indicators, if it was not enough of those indicators, then we could say, well, I'm going to go on and do an objective examination. What that then highlights is what must you do on day one, and what impact, as the girls have already explained, would the SIN value have on that. Okay. For the purposes of time, I'm not going to explore, but this is where we will get to. I have scheduled, if I remember correctly, your first clinical reasoning panel for, I think it's week 2 or week 3, can't remember which week. We will be doing it like this. What happens in reality, well, this is reality, but what happens in the practice of a class is that it won't be the same 3 people that are there all of the time. It will be 3 people that will rotate in and out of the panel, and the audience is asked questions as well, so you've got the opportunity not for me to be firing questions at you, but the audience is asked to answer questions as well, and that then allows us to explore as a group your knowledge and your understanding. We would present, you'll only get to the end of subjective. Your first panel will take you to this very point. What we will do, however, over the course of the first week, 6 weeks, is develop on from that to demonstrate your knowledge of the tests for the hip, the knee and the ankle, and we will give you data, okay, that you will have to explore and interpret, and then at the end of that you would then reason, were they as you expected? Why were they as expected? Justify that. And that's really where you move your clinical reasoning and decision making from, even our undergrads do this, but certainly into M level, we're moving, trying to get you to the end of week 12 to get to that point you can justify everything that you're doing. You at least have a very good stab at justifying what you're doing. When we would get to that point, we may add in other data that comes from other aspects, and you would then be asked to explore how that fits or doesn't fit. Bit of a whistle stop. Thoughts from the audience? I'm not seeing many. Can you see, this is what I always have you guys. Are we excited? Is that to see where the bits are fit together? Are we scared senseless? You guys have been through it, and I know Becca's already had a bit of a chat to you've been through it. You were not in as much detail, obviously, as these guys are going to do, because obviously we've changed the programme from you. But you've been through it in NMSK1, and you've been through clinical reasoning panels and this type of strategy, certainly a lot in NMSK2. What's your thoughts and comments on it?
It gets easier.
They are really like these scary senses at first. Like Laura, who's not.
That was a good sales pitch, thanks, Dana.
Laura meant to be here. We used to laugh because she used to sit up here with her face, and you could just tell that she was sitting up there absolutely petrified. But by the time you finish week 12 and then you go out on placement, once you've done these, you know what to expect on placement. It's exactly the same thing, apart from instead of doing it with a set of slides, doing it with a real patient. And actually it's easier than with a real patient because you can ask the questions that you can't ask now. But if you can get through the first couple, it actually starts to enjoy them.
The first time we did one of these, we'd never seen one before,
Yeah,
and we
so
were
it's
just
just
be like, we're doing a clinical reasoning panel today. Okay.
Now you'll
it's
find
quite
you're doing a
good
demo.
to see.
And just come up and do it. Like, I used to be really terrified, but if you just push yourself to do it, it's a lot easier than what it looks like. It maybe sounds like we've kind of blabbed on about a lot of stuff that you might not know yet. Like, I wouldn't have known any of this if I was sitting in your position now. But it is easier once you're actually sitting here, because your thoughts do come to you as you're talking, and Fiona kind of helps you bring it out eventually if you're struggling. And you guys will be asked questions, so like if we were struggling, then the questions kind of get thrown at you guys, and then you understand where you're trying to be.
Chances are somebody in the room
Yeah.
knows that, and so we build the bits and pieces up. So again, we talked yesterday about teaching and learning strategies not being me standing here saying this is the word according to. This is how, it's not just clinical reasoning panels, there's other ways that we would do it, but this whole idea of you developing and enhancing your own understanding of something as opposed to being sponges and just absorbing, because what you then do is it's called constructivist theory. You construct your own understanding of something, which then should make an awful lot more sense when you do go out into the practice situation. So we deliberately align these to the whole process, obviously from the tutors that we've got within the school, academic tutors as well as our clinical colleagues. We've had those experiences as practice educators. I've worked with students as a practice educator in the clinical environment. I've worked with inexperienced practitioners as a mentor, and these are the things that we develop. We're developing a process. Okay, so we're not just pouring in information. As girls say, it's that process of how it all fits together, and so you then get the opportunity to explore different ways of doing that when you get onto practice. So it's really just to give you a bit of an introduction. Does anyone get any questions? Day 5, they're all like, and he's about to yawn again.
Be careful.
Be warned, be warned. Okay, if there are no questions, what I will do, this will be uploaded, downloaded, whatever Gordon does to it, and I will load it up onto the integrated neuromusculoskeletal practice site along with this presentation, so you can have a look at it. You can also use this. This wasn't my data. I played around with it a little bit from Alistair, so not all of it is presented in the way that I would probably be advocating that you do, but it will give you an introduction to the type of data we're going to be talking about next week in an integrated session, and the kind of the sections and the way we start to record information, and we'll expand on that with some other examples. So that will be up onto GCU Learn for you to look at. Yes.
You mentioned the name of Jeff Maitland.
Yes.
Is that something you're going to introduce us to a couple of weeks and we should be starting stuff?
Yes. You'll be introduced to a number of different gurus is probably something a little bit kind of negative word. You've been introduced to a number of different approaches. If you look at, I'm not quite sure what Tom's written into the handbook, but we explore across the programme Jeff Maitland, Cyriax, Carlton Bourne. We explore different aspects, certainly into NMSK2, different aspects from the kind of Edwards principles, Mackenzie principles. So you're introduced to a number of different philosophies from different people depending on the background. This is all NMSK. We tend to hang, we are not saying Maitland is it, but in terms of teaching you principles of how to hang something, and certainly planning your subjective and objective examination, a lot of the work looking at the semi-permeable brick wall, hypothetical deductive reasoning, we use Jeff Maitland's philosophies. We don't tell you to go and read peripheral mobilisation, the Maitland text. I would suggest they'll put it up actually onto GCU Learn, that you have a look at the chapter about communication and interviewing after next week. So you'll dip in and out of lots of things, but certainly the whole idea of sin value is Maitland concept, and it just allows it's a framework that you can establish some kind of idea into. Okay, I think Shiv's either loitering outside the door or imminently arriving, so you can have a slight break. Before I do, actually, I forgot, you mentioned to me yesterday in the corridor, in terms of the anatomy textbook, so I don't even know your name.
Right.
Said to me, can we use the pocket version? My quick answer to that is use the pocket version as an adjunct to the bigger version. It's not nearly, it's great for clinical because you've got an anatomy textbook that stays in your bag or your pocket that's not huge, but you need depth. So if you've got a pocket version and you want to spend some time with a loan version of the bigger one from the library, that's fine, but the depth of detail that I'm going to be expecting from you, you're not going to get in the pocket version. Yeah, so just to pick that.
I don't know if the big one's online.
Yeah, I think we all use the online version of the big one.
It should be available because we moved the university tried to get at least can't remember what percentage of our textbooks that go onto your reading list electronically. I am aware though that some people, and I am one of them, that don't really like learning things online. I find it a bit of a
You can
struggle.
also, if you've got an
You can download.
iPad, you can download it for 24 hours, and then that's quite good for the. And then what I did was did like post-it notes or flashcards, and then put it inside the pocket version, because the pocket version is significantly cheaper and significantly lighter than the big version.
There's also, if you can't get the newest edition, there's loads of the old edition.
Yeah, the 2006, and there's not huge differences between
Just
2006.
different page
It's,
numbers.
yeah, they tended to condense it, they just squashed it in, so it's a bit smaller. Okay. You guys are spending some time with them this afternoon, is that the plan? Will you meeting them again?
We've got walkabout booked for 12:30. We're hoping
Social visit.
that some people will come along if they've not got stuck with the wind.
Yeah, other people from our